Participating doctors, a warm welcome on behalf of Shield Healthcare, and thank you very much for joining. Before we begin,
Madam,
we
good
have
evening,
a
madam.
short.
Good evening.
Afternoon.
Good afternoon, Mr.
Doctor,
Balaji.
good evening. Dr. Sushila Rani, madam.
Yeah, good evening. Who's
Good
that?
evening.
Mr. Balaji?
Yeah, it is Balaji only.
Yes.
Yes. Go ahead, Dr. Prachi.
Yeah, thank you. So before we begin, we have a short AV on Shield, and so requesting Chitra to play that AV. Chitra, over to you. This is our Shell Connect website. We have all the webinars and various blogs available on this, and all our meetings are also and webinars are also conducted via Shell Connect. So this is our new development, new initiative, and requesting doctors to please visit our Shell Connect website. So thank you very much. So today we have a panel discussion on PCOS in adolescents, challenges in diagnosis and treatment. We have eminent speakers, and I'm very happy and privileged to introduce all these eminent speakers. Starting with Dr. Sushila Rani, ma'am would be moderating today's panel discussion. Ma'am needs no introduction. She is Director, Manjushri Specialty Hospital, Consultant Vikram and Bhagwan Mahavir Jain Hospitals, Chairperson, Postgraduate Forum, Bangalore Ops Society, past President of Bangalore Society of Ops and Scientific Chairperson, AICOG 2019, and National Advisor, AICOG 2020. We also have Dr.Thejavathy, President, BSOT 2020-21, Unit Head Ops Department, Bhagwan Jain Hospital, Consultant, HBS Hospital and Motherhood Hospital, undergraduate and postgraduate teacher for more than 18 years, and contributed articles to Foxy Focus and chapters to various books. Our another panelist, Dr.Jyothika Desai, Senior Consultant, Dr. P.R. Desai Hospital, Bangalore, President, Bengaluru Menopause Society 2016 to 2020, DNB Teaching Faculty, CSI Hospital, Bangalore, past President of Bangalore Society 2013 to 14, FOXY South Zone Quiz Coordinator, organized several major conferences, winner of various awards and a chain of gold medals, written several articles for reputed scientific journals, and has edited several books. And Dr. Ramarajan, former head of Department Ops of CSI Hospital, Bangalore, past President, Bangalore Society of Ops, former senior consultant at Santosh, Bhagwan Mahavir Jain and Vikram Hospitals, popular postgraduate teacher, edited several books including SAMM monograph on anemia, published articles in national and international journals, special interest in high-risk pregnancies and colposcopy, and scientific chairperson AICOG 2019. So with this, I'm so sorry, Dr. Jayati Dureja, Obs gynecologist with fellowship in fetal medicine and IVF, currently working as a consultant gynecologist and director at Pulse Medical Center, New Delhi. Ma'am has a special interest in fetal medicine and prenatal genetics, endocrinological disorders in women, especially PCOS and GDM, and application of nutritional therapy and fitness in improving women's health. Actively involved in spreading awareness about women's health during the lockdown, she turned to podcasts to reach out to a wider audiences. Ma'am was recently invited to clear the air about PCOS on the Candid Fitness on Spotify, Apple, and YouTube in November 2020. So with this, thank you very much, doctors, for joining this panel. And over to you, ma'am. Dr. Sushila Rani, over to you to moderate this session.
Thank you, Prachi. I think I'll share my screen now.
Yes, ma'am.
Is it visible?
Yes, ma'am.
Okay. Now, the topic for today is PCOS in adolescents. And more importantly, we are going to discuss about the challenges that we face in diagnosing PCOS in adolescents and the treatment aspect of it. And to discuss this, we have very eminent faculty, including my friends Dr.Jyothika Desai, Dr.Arulmozhi, Dr.Thejavathy, and Dr.Jayati Dureja. We all realize that there is an increase in the incidence of polycystic ovarian syndrome, not only in the general population, but amongst a very important segment of our women, that is the adolescents. In order to drive home certain points about the diagnosis and the treatment aspect of it, I thought we'll take it through a case discussion. Here we have a typical case. A 17-year-old girl presents with irregular, infrequent periods, say once in 2 to 3 months since 1 year. The age of menarche is about 12 years, and she also has severe acne not responding to topical therapy, causing embarrassment. History of excessive weight gain in the past 6 months with inability to lose gained weight. Now, to all my faculty here, I also want to say that she has had an abdominal ultrasound with a normal appearing uterus and bilateral normal ovaries. Specifically, there was no evidence of polycystic ovaries in the ultrasound. Now, I want to know, does this girl have PCOS at all? Does this girl have PCOS?
Yes.
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 Yes. So all of you feel that she definitely has PCOS.
Yeah.
Okay. Now, having said that, the diagnosis of polycystic ovary syndrome in adolescents consists of ovarian dysfunction, and this girl has shown ovarian dysfunction in the form of irregular menstrual periods and androgen excess in the form of acne, which is not responding to topical therapy. Therefore, we know that she's having PCOS. Now, having confirmed that you feel that she has had PCOS, Dr. Arul, how would you differentiate normal physiological adolescent anovulation, that is the irregular periods that happens generally immediately in the pubertal period, from true ovulatory dysfunction? When is irregular menstrual cycle in an adolescent actually abnormal?
Okay. presuming that this girl has started menstruating, the question of amenorrhea, primary amenorrhea, is excluded. Now, when an adolescent is coming in with irregular periods, the very first year after attaining menarche, she may have any kind of periods, and that would be considered physiological, meaning any pattern is accepted as okay. After that, from about 1 to 3 years, she is expected to gradually normalize with cycles happening from about 3 to 6 to 8 weeks. To put it precisely, about once in 21 to about 40 days. If that happens, then that is normal. But if at any point in time she does not get periods for 3 months, that is more than 90 days, then it is abnormal. Beyond 3 years of attaining menarche, up to 8 years and beyond, her periods must happen at least once in a period of 21 to 35 days. That would be absolutely normal, and anything that does not fit into this would be called as out of physiological range. So this would be how I would analyze it and accordingly counsel the lady.
Wonderful.
Girl.
I think because the typical pattern of menstrual cycle being 21 to 35 days that we normally get to see in adult women may not happen in this. So we need to give time for the menstrual cycles to be established. But despite that, there are certain things like, a period of less than 21 to more than 45 days in the after 1 year is considered abnormal. And similarly, like you said, if she has not had periods for almost 3 months in the year or in any one of the cycle, or if she has not attained menarche by the age of 15 years, or she has had breast budding and the breast thilarche happening, but still she has not got periods, and then we would definitely consider the possibility that this is definitely an irregular cycle. Now, coming to the androgen excess aspect of it, Dr. Jyothika, acne, hirsutism is all common among adolescents. And I'm sure all of our girls have gone through, and we ourselves have gone through some amount of acne, some amount of hirsutism, and worried about a pimple here and a pimple there. But when would you actually call it as an androgen excess in an adolescent?
Yeah, you're right, Sushila, that adolescents usually have a little bit of acne and a little bit of hirsutism, which troubles them a lot. But we cannot just label that as androgen excess. It is only when there is acne which does not respond to topical treatment and it persists. That's one reason, which we can say is because it's due to hyperandrogenism. Again, hirsutism. Now, when we talk of hirsutism, we don't say that there is excess of hair. It is only the character of the hair which
Exactly.
becomes terminal hair. And this is usually seen in androgen sensitive areas of the body. Now, whenever there is, so we have something called a modified Ferriman-Galway scale. According to that, there are 9 sites which have been identified, and a score of 0 to 4 is given. So 36 naturally is the highest score. But if the child, the adolescent rather, has a score of between 6 to 8, then you would think that that is because of hyperandrogenism. And lastly, alopecia. Now, alopecia is not very common amongst adolescents, and we have something called frontal alopecia. And of course, we have the Ludwig score the Ludwig scale rather, by which we can assess alopecia. But if alopecia is also there, then we would definitely say that this is due to hyperandrogenism or androgen excess. And lastly, the biochemical test. You do a serum free testosterone or a total testosterone. Not just this, there are other ways of doing it. But if these are persistently elevated, then again you can call it as androgen excess.
Yeah, wonderful. Like you said, when there is severe hirsutism, when there is acne, which is really becoming bothersome, or when the androgens are biochemically elevated, like the levels are actually elevated, then definitely we would call it as an androgen excess situation. Now, having said that, Dr. Teja, we always hear of, and I think, patients seem to be more aware of this because they come and throw the report of ultrasound in front of us and say, "Doctor, I have PCOS." Now, what exactly is PCO or PCOM or PCOS? What do they actually mean? When we say PCOM, what are we talking about?
PCOM is polycystic ovarian morphology. When you do a transvaginal scan and you find a follicle number more than 20 per ovary, or if the ovarian volume is more equal to or more than 10 ml, then you call it as polycystic ovarian morphology. This is on transvaginal scan. But when you do a trans-abdominal scan, you only consider the ovarian volume, which is around equal or more than 10 ml, because it's very difficult to count the number of follicles on trans-abdominal. So, whereas polycystic ovarian syndrome is, when you have the other features like hyperandrogenism and ovulatory dysfunction, with of course plus or minus of other metabolic features, then it is called as syndrome. But having said that, it doesn't mean that if she has PCOM, she definitely has, PCOS, because in spite of having morphology, she may not have any symptoms of PCOS. In contrast, she may have PCOS and her pelvic scan may show absolutely normal ovaries.
Wonderful.
So this is, it's to say that if it is PCOM, about 30% of the normal adolescents can show a PCOM morphology. So you have to be a little careful.
It's very well put across. Like, earlier we used to count the number of follicles, but then in a transabdominal scan, that may not be possible. Now, with the better and better machines, ultrasound machines, we are able to count and actually get the total number of follicles in each ovary. But having said that, it is the total ovarian volume that is important. And this ovarian volume varies from age to age also. It is different in an adolescent. It could be almost up to 12 centimeter, whereas in as the age increases, the ovarian volume also. But on an average, when it is around 10 ml, then we would consider it as polycystic ovaries. Now, you also said that the PCOM, that is that morphology, can be seen in normal women, whereas actual women with the diagnosis of polycystic ovarian syndrome may not show the morphology on ultrasound scan. So should we do an ultrasound in this particular girl to find out whether she has got PCOM at all, Dr. Teja?
No, for diagnosis of PCOS, particularly in this age group, it is not at all recommended, because they say the first 10 years post-menarche, you're not supposed to get a scan done just to diagnose PCOS, because there are multifollicular picture in ovaries in this particular age group, the first 8 years post-menarche. So you may overdiagnose the PCOS. So that is a reason that you need to keep the ultrasound away from the investigation in a PCOS girl.
Yeah, not just for the sake of diagnosing PCO morphology, we definitely don't need to do an ultrasound. So in an adolescent, that is one take-home message, that definitely we don't need to do an ultrasound to look for a PCO morphology in adolescents, because that will not be helpful to arrive at a diagnosis. We arrive at a diagnosis based on the ovarian dysfunction and based on the androgen excess, and we do not depend upon the PCO morphology on ultrasound. Now, Dr. Jayati.
One point I would like to add.
Yeah.
One point I would like to add. Now, in adolescents, we hardly ever get an transvaginal scan done.
Yeah.
And what reports they come with are all abdominal scans. Generally, it is abdomen and pelvis. Very sort of a generalized ultrasound picture. And if at all these girls had menstrual abnormalities, they would have come directly to the gynecologist. Because they had more of acne and other issues, they probably go to a dermatologist or a general practitioner and get a scan done. So it may not really be PCOS, and as Dr. Teja has put it across, a good amount of overdiagnosis is happening.
Yeah, overdiagnosis can happen. Dr. Jayati, what are the difficulties in diagnosing PCOS in adolescents? Why do you think it is difficult for us to actually pinpoint and say, yes, this girl has got PCOS, or no, this girl doesn't have PCOS? What are the problems that we face?
So when we think of PCOS, the first thought that comes to our head is the Rotterdam criteria, which talks about menstrual irregularity and hyperandrogenic features, whether it's acne or hirsutism, and the third being PCO morphology on scan. However, in adolescents, this is a part of the normal spectrum. Like Dr. Thejavathy said, PCO morphology is 30% of normal adolescents. And hyperandrogenic features are again associated with puberty. They're synonymous with puberty. There will be sexual well as hair growth. There will be acne that come in this age group. So we have to be very careful when we're diagnosing acne as a hyperandrogenic symptom of PCOS. We have to make sure it's the inflammatory type of acne, which is not responding to topical treatment, and then think of diagnosing towards PCOS. And again, as Dr. Arul mentioned, menstrual irregularity, that's seen in 85% of adolescents in the first year of menarche. And if it has still not regularized by the third year is when I would, in combination with excess androgenic features, I would think of diagnosing PCOS. And then also I would like to label it as at risk for PCOS rather than labeling PCOS.
Yeah, we'll come to that, Jayati. We'll come to that. So the problems that we face in diagnosing PCOS in adolescents is many of the diagnostic criteria by which we go for diagnosing PCOS in an adult are a little gray here because they already happen in a girl who's going through puberty. Whether it is menstrual irregularities or whether it is acne or hirsutism or the PCO morphology. These are the features by which we go to make a diagnosis, and that may already be happening. So to say definitely that she's having PCOS, we definitely need to have some solid criteria. Otherwise, we'll be labeling every other girl as having PCOS, which may not be appropriate. So like Dr. said, yeah.
There's overlapping of the features, normal in the physiological and pathological.
Yes,
so
Jyothika.
this is the main problem. Yeah.
Yes, Jyothika.
Yeah, it is very important that we don't label them as PCOS because the prognosis is bad for PCOS. So once, the child or the adolescent thinks that she has PCOS, she's sort of funked all the time. She's scared. She comes to the hospital, any hospital say, I've been diagnosed with PCOS or PCOS or whatever, as if, it's one big disease which is hanging over her head. So we need to be careful and not give them unnecessary labels, as PCOS, like how we are going to come to it, of course. At risk is always a better proposition.
Yeah.
Always follow them up.
So here's one 14-year-old
And
girl.
when you
here's a 14-year-old girl with cycles which are once in 2 to 2.5 months. Her bleeding is heavy and this periods last for almost 2 to 3 weeks. She attained menarche at 12 years. So it's 2 years since her menarche. And she has a mild acne and has recently gained 7 kgs in 1 year. Her BMI is now 29. Would you label this girl as having PCOS?
We just now discussed that labeling. No, I think we can just put it as at risk and have a careful, reassessment later. So that we can be very sure of our diagnosis.
Yeah, that's the Teja. What about you, Dr. Jayati? Would you call this patient as having PCOS, or would you tell her, no, this is part of puberty, you can go home?
The heavy bleeding is definitely not normal. I would evaluate that further, but overall, I would not label her as PCOS.
You will not label her as PCOS. Yes, Dr. Jyothika?
Yeah, this girl has irregular periods showing that she has ovulatory dysfunction, but she does not have hyperandrogenism, which is one of the main features of PCOS. Obesity, you cannot consider obesity as hyperandrogenism. So that's the reason why, because the picture is not complete, we cannot diagnose her as PCOS. Put the diagnosis as at risk And more than anything else, it is not necessary that we don't treat her. We counsel her and we treat her just as we would.
This label of at risk is very nice.
Yes, Arul?
Yeah.
This label of at risk is very nice. And, it sort of alerts the girl and her mother
Yes.
to
Yeah.
a better lifestyle.
Yes.
So that, they think, okay, if I do as I'm advised, I'm going to probably avoid becoming one PCOS free person.
Alerts the gynecologist also,
Yeah.
apart from the mother and daughter.
It definitely means that this girl needs to be under observation.
Yes.
She needs to be under observation both by the doctor and by the family also for the possible development into a PCOS. So they need to then take care. It's like a pre-diabetic. Pre-diabetic is like a warning. Anytime you can become diabetic, so do all that you want to do before you get the label of diabetes. So definitely at risk is what we would say in this case, because she only has menstrual irregularities. Now,
Also, I read about how obesity results in a pseudo PCOS kind of situation. So her high BMI is mostly contributing to the irregular cycle. So that part of counseling has to be done. Yes.
Yeah, very true. They come and say that it's because of my irregular periods or my amenorrhea that
I put on weight.
not weight. Yeah, I tell them it is the other way around.
Yes.
Do not blame the obesity for their irregular cycles. So, what are the common presenting symptoms in an adolescent PCOS? What are the symptoms that we get to see? Anyone, Teja?
Most of the times it's menstrual irregularities. Most of the time, either they come with saying cycles are irregular once in 2 months, 3 months, or sometimes only induced cycles, or heavy prolonged periods. These are the commonest symptoms. Apart from this, of course, few of them do come with hirsutism and excessive hair growth and acne. And of course, associated with this, you can get the history of weight gain also, most of the times. And a small portion may have normal cycles with maybe features of mild acne or hirsutism or increasing weight gain.
Yeah, the increase in weight gain has become a common feature ever since we have had this lockdown, and we are getting to see more and more pictures of menstrual irregularity with weight gain. May or may not be associated with the androgen excess. Now we'll come back to, we'll come back to our girl who, this is that 17-year-old girl that I was talking to you about with irregular cycles, excessive weight gain, acne, not responding to topical treatment. On examination, her height is 160, her weight is 83 kgs, and her BMI is 32.1. Her blood pressure, she's 17-year-old, her blood pressure is 130/90, and her waist circumference is 102 centimeters. There are multiple papules and nodules and comedones on the face, which goes to say that we are dealing with a moderate to severe form of acne. Now you order for a pregnancy test, and that comes negative. Dr. Arul, what test would you order in this patient? Now she's come to us. We have made a clinical diagnosis or assumption that this is PCOS. What test would you order and why would you order them? I'm sure you will not order for a scan.
Well, why do we order tests in the first place? It is to either make a diagnosis or to see how severe it is or how to go about with further medical or surgical management, isn't it?
Yeah.
So in this situation, her diagnosis is made. It's given to you on platter, and I wouldn't want any further investigations to make a diagnosis because PCOS essentially is a clinical matter.
Yeah, Jyothika is
however
to say.
This patient is obese. That's one thing. She is hypertensive too. Of course, you cannot be very sure about the hypertension because none of us have obesity, so it can just show
anxiety,
a higher BP because the cuff is not exact to our arm circumference. So when we have all these together,
or anxiety also
possible, yeah, correct. So what I would suggest that we do a glucose challenge, OGTT.
GTT.
OGTT and HbA1c are essential in this patient, very important. Then her BP, of course, is high. You wouldn't expect anything like urea and creatinine in this place, in this age. But even then, I would order that. That's one thing. Second, I would like to see how bad her testosterone and her free androgen index are. Does she warrant treatment for it?
Yeah, we'll take Arul's opinion on this also. Because you started saying something, Arul, what are the investigations you would offer?
I fully agree with whatever Dr. Jyothika has brought out. I would, if her androgen issue is severe, like how she has her comedones, etc., getting her testosterone levels would be okay, appropriate. But in this testosterone business, we cannot just read off a report and say, yes, you are out of range or you are within range, so you cannot bother about your symptoms, etc. Because some labs will give you total testosterone, some will give you free testosterone, some will give you calculated free testosterone or free androgen index. Now, out of all these, according to the Rotterdam consensus, the recommendation for good predictive value would be on the calculated free testosterone or free androgen index. This index is actually the ratio of testosterone total to SHBG. And if this exceeds a value of 2, then she falls into a hyperandrogenic state. If all these are normal, then I would think about an adrenal source for these androgenic elements. And then I would go ahead with testing her androstenedione or DHEAs. That's about the male hormone levels. Apart from that, certainly she needs an OGCT or even a plain fasting blood sugar or A1C to know if she's falling into dysglycemic range. This would happen if she is of high risk ethnicity, has parents who have diabetes, or she is very obese as she is now. So all these also are important in getting her OGCT done or her glycemic status revealed. So this would be my investigation levels. I wouldn't really go into testing her FSH and LH, etc. Because we know that in PCOS, the ratio is reversed, LH to FSH, and that doesn't tell us any extra about handling her. Getting a thyroid stimulating hormone done would be appropriate because her weight gain sometimes may be an add-on. Yes, thyroid may also show some dysfunction and it will help correcting the overall picture. So this is
prolactin also?
Because
for pituitary overall assessment can get it done. But these are all okay. Even without it, I would know it's PCOS and I would treat her accordingly and appropriately.
If there are, basically, PCOS is a clinical diagnosis. Now, if at all you're ordering some investigations, it is to find out if it is to make sure that that is the diagnosis and to rule out all the other causes. So you have to make sure that she does not have a non-classical congenital adrenal hyperplasia. You have to make sure that she does not have probably an adrenal tumor or an ovarian androgen tumor. Now, all these would mean that that's the reason probably we'll get a total and calculated free testosterone, because the testosterone values are different in different situations, though all of them can give rise to an androgen situation. Yes. Now, once we confirm FSH, LH, and estradiol levels are important because these days, when they come with amenorrhea, we do get to see many women with many young girls with premature ovarian insufficiency. So only in those cases, yes, ordering an FSH and LH would be appropriate. Once we diagnose PCOS, we'll need to run a OGTT like Dr. Jyothika said. And of course, we also need to get a complete lipid panel done. How do you diagnose clinical hyperandrogenism? Dr. Jyothika, you already told me a lot about this, but if we can go again through when you would say with the basis of acne or the basis of hirsutism, when you would call it as clinical hyperandrogenism as against the little androgen excess that you get to see in puberty?
Yeah, you're right, Sushila. Little androgen excess is always there. But when, I've already told you that it could be manifest as acne, hirsutism, or alopecia. Now, when we think about acne, it's not just one pimple here and one pimple there. It has to be more than 10 comedones, on the face. Now, if a girl rather comes with that sort of a picture, then you have to think only of androgen excess and nothing else. That is about acne. Now, the other thing is about hirsutism. I've already mentioned about the different areas where you need to look out for hirsutism, about terminal hair, and if it is more than 6 to 8, according to the modified Ferriman-Galway scale, then, we need to think about hirsutism. Again, when these girls come to us in the beginning and we treat them for hirsutism and for acne with combined oral contraceptives, if by 6 months it doesn't disappear, then also we think, more in favor of androgen excess than just plain puberty. And of course, alopecia is not common in adolescents, and frontal alopecia, it's called androgen type alopecia. That is what is more special about these cases. And of course, we have the Ludwig scale by which we can evaluate it, the extent of the alopecia. And if alopecia is there, then the treatment has to be given. Anti-androgens have to be given. We just can't treat it with COCs.
Thank you, Jyothika. Now, Dr. Thejavathy, when there is clinical hyperandrogenism, when clinically she has got all the features of hyperandrogenism, do we really need to check the androgen level, say testosterone or free testosterone or total testosterone or DHEAs, all these androgens? When she's already having all these features, do we need to really check these levels?
Just now we discussed the causes of hyperandrogenism. If we want to rule out where exactly the androgens are coming from and the severity, yes, in that case. And secondly, in case of absence, if there is no excessive hair growth or acne, and you're because she has ovulatory dysfunction, and if you're thinking of and a little bit of weight gain, and you want to make sure, then of course when the cause of the hirsutism or acne is unclear, in that case also you would like to get, even though there is clinical hyperandrogenism.
Yeah, thank you. So now, having said that, biochemical hyperandrogenism is where the hormone levels are high, but they do not have all the features of androgen excess. When we run calculated free testosterone or free androgen index, we find that the levels are high, and then it would probably indicate a biochemical hyperandrogenism. It need not be clinical all the time. When you strongly suspect that this could be a case of PCOS, we do run these tests to find out if they have biochemical hyperandrogenism. More often than not, they do show features of androgen excess. Androstenedione and DHEAs you do only if the testosterone is not elevated and you do find features of androgen clinical features. Yes, Dr. Jyothika?
Yeah, I would just like to add here, free androgen index should not be done if the adolescent has been on COCs for some time.
Yeah.
3 months, at least 3 months.
Increases the sex hormone binding globulin. So
Yeah.
what happens is that the circulating androgens are decreased. So in case you want to check out, then the girl has to be 3 months without COCs, and only then you can think of doing the FAI.
Yes.
That's an excellent point there. Like quite often when they do come to us, they're already on some hormones or the other. And if that is the case, then we have to wait for 3 months for a washout and then get all these hormones evaluated. Now, Dr. Jayati, you have decided to get the test done. You have decided to get all these tests done. When should the blood be drawn? Do we draw it any time of the day, or do we have any time of the cycle? Is there any preferential time that would give us better
Accuracy.
yeah.
So I have to be careful of two things. The first being the time in the cycle, preferably in the early follicular phase, because mid-cycle and onwards, there's a natural tendency for androgens to increase, especially around mid-cycle with the LH surge, the androgens increase. And the second would be to get an early morning sample drawn for the testosterone levels. That's the most predictive and what we can correlate with our data.
Very good. So testosterone may be increased in mid-cycle, therefore preferably done in an early follicular phase, and morning levels are more predictive. What about AMH? There is a lab package for PCOS. There is a package for everything for that matter. Package for POH, package for PCOS. Now the lab says we have it comes with the package. Do you think AMH is going to be useful in the diagnosis of PCOS in an adolescent?
So we do know that AMH is highly raised in girls or women with PCOS. Even up to 75 times the normal level of AMH can be found in PCOS women. However, a lot of labs use different assays, and also the levels of AMH to be used as a cutoff is not available in literature. So we don't use it as a diagnostic marker, but later on when we're assessing for fertility, we do use it as a prognostic marker. So I wouldn't do it in an adolescent.
Yeah, in an adolescent, definitely there's no question of fertility here. Of course, if they do want to, but then we are looking at girls less than 18.
Yes.
So with that, AMH definitely is not an indicated investigation in an adolescent with PCOS. You have diagnosed PCOS, Dr. Arul. What would you do next? Like, you've already diagnosed PCOS. Clinically, you said you will do it and you are fairly certain, yes. And now you have the lab results also. What would you do next?
The first thing would be to have the girl and her, ideally her mother, and sit and talk to them, because counseling is one huge part of managing PCOS. So first of all, I tell them that this is a pretty common condition. It is not a disease as yet. It's only a syndrome, which means an association of some signs and symptoms. And therefore, she is still she hasn't stepped into a red zone as yet. And she need not be scared of it. There are, of course, fallouts, immediate and long-term fallouts of PCOS. I would explain that to them. She already has come up with the short-term issues like irregular periods and acne and other symptoms. So she understands that. And of course, excessive weight gain. So on all these issues, I will tell her how she can sort of rectify it, and tell her that much of the treatment depends on her commitment to a change in lifestyle. And a part of it, of course, is on the doctor's side, where the hormone fluctuations or the little deviations will get corrected with treatment. And if she abides by the advice totally, then the resolution of the condition is almost there. So we can counsel her on all this. And of course, tell the mother and the girl not to sort of compare with her friends, discuss this with her friends, and go on and on and on about it, which will only increase her stress about it and not work positively. So that's one thing. Then I will think about what medication I would give her. Shall I go with medication, or do we have someone to address medication?
We'll discuss that later.
Okay.
Basically, like in any other clinical situation, when it comes to talking to patients, it is very, very important. Counseling plays a major role, and you have highlighted the importance of counseling, especially in an adolescent who comes with PCOS, because it can make a lot of difference to the way she takes the diagnosis. How she takes and how she reacts to it is a lot dependent on how we counsel her also. So lifestyle modification, yes, it can normalize a whole lot of things. And when we say lifestyle modification, we are talking about diet and exercise here. It can improve the score. It can normalize many of the androgen excess, and it can normalize the FSH values also, and overall it can bring about a whole lot of change. So in the management of PCOS, lifestyle is the fundamental stone. It is the foundation stone of the treatment of PCOS, and subsequently whatever treatment we give is based on whatever complaint she comes up with. Now, having said that, what changes, Dr. Jyothika, what changes would you suggest for an adolescent with PCOS?
Most of our adolescents may not listen to us when we suggest lifestyle modifications, because whatever we suggest is totally against what they enjoy.
Exactly.
So we would start with food, which is the most important thing for them right now. So for food, first tell them that they should not have junk food. And when once you said that, you become the instant enemy. The next thing is that they should not diet. Now, whenever you say you have to lose weight, the only thing they can think of is a keto diet, some diet or the other. So we tell them that they should not go on a diet. And second thing is they should not have any fasting, like, missing a meal totally, skipping meals. All these are not in the agenda. What they have to do is they have to use less carbs, more proteins. And of course, we have to teach them the plate meal type of dieting, where food habits, where they'll be having more of proteins, less of carbohydrates, and more of vegetables and fruits. All these are very important. And apart from this, of course, they should have good exercise. I think we're going to deal about exercise later on.
Yeah.
So I'll not stress too much about that. Good sleep, a positive attitude, and a commitment to what they want to become. At least if they lose about 5% of their weight, the whole picture can change beautifully.
Yeah, I agree with you, Jyothika. Like the moment you say, no, I don't start with don't eat that, don't eat this. I tell them you want to eat pizza, you want to eat burger, you can go ahead and eat it, but eat only once a week. So they know that the rest of the 6 days they are not allowed to eat that. So this makes a little bit of a difference instead of asking them to stop eating. And basically, I start with the question of, how they would like to bring about a change. Like, what do you think you can do in this kind of situation? And when it comes to weight loss also, I ask them, how much do you think you can manage weight loss? Usually they come up with a very big figure initially. But then, when we tell them to have a little more practical numbers, then they come up with a better number. So when they make a commitment, it happens. Yes, Teja?
I just wanted to add, when you advise them about this diet, it's important that the mother is there, and then she also understands and makes changes in what she cooks to the entire family, so that the girl alone is not isolated and given a different kind of food. So exactly. I think that also is very important.
Exactly.
Very, 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 very true. If you have them both sitting across the table, you can make out very well. The mother is very happy that you are advising this way. That girl is giving daggers to mother, saying, why did you ever bring this?
Very true. Very, very true. Yeah. And I've been telling you.
One time.
Yeah.
Family can do.
Yeah.
Yeah. Regarding asking the girl as to what she wishes to be, like Sushila asked, you probably, if she gets into big time thinking, ask her to have some short term goals. The next 2 months you drop so many kgs, next further 2 months so much, like that, instead of having a huge task ahead.
Yeah, and usually in girls who have some food fads, there is another family member or a senior family member, maybe the father or maybe the elder brother or an uncle, who is probably doing all these things. So you need to correct the entire family. I tell the mother not to cook separately for her, but to cook the same thing for the entire family, so that the entire family is healthy. After all, what we are going to suggest is going to be healthy for the entire family. And obesity will run in families. So it will work for the mother, father, and whoever is obese in the family.
Because they don't run.
They don't run. So the family has to run.
It runs in the family because they don't run.
I think we can even give some realistic goals. like one snack is usually 200 to 300 calories if they're already eating junk food. So just stopping that one bad snack a day plus doing exercise which burns about 200 300 calories a day, that would result in 1 kg loss in 2 weeks, because you need to burn 7,000 calories to lose 1 kg. So maybe sometimes giving that sort of a figure to them with the goal of just make a change of 500 calories per day in your life, and slowly over time it would make a difference. I think that could also help.
Yeah. When it comes to exercise, I think who else to ask? Jayati. She says she walks to her college. She says she walks to her college every day for a total of 45 minutes. But she has not. Now you mention exercise. She says, I do all the walking. I go to the college and come back, but I not lost weight. So how do you quantify the exercise that needs to be done? Jayati, like, for a young girl, she says, no, I go for a walk. A moonlight walk is not as the same as a brisk walk.
Yes.
And the amount of calories that are burnt is different in each. So how do you put it across scientifically to her?
So scientifically, we have a measure called metabolic equivalence that helps us categorize light exercise, moderate, and heavy exercise. So a simple stroll like what she's doing is still coming into, it's slightly better than standing. It's not making too much of a difference as far as exercise is concerned per day. So I will tell her to continue that, but also add on something which is moderate to vigorous. And ideally, a combination of cardio and strength training in adolescence is preferred, at least 60 minutes per day of cardio plus strength, out of which 3 days are dedicated to muscle and bone strength training. And as you can see, moderate is more than 3 metabolic equivalents, and vigorous is more than 6. So a lot of adolescents anyway do like to play sports. So I'll advise bicycling or playing tennis or going to play football in the evenings, or even going for a jog. And then definitely strength training does require a bit of supervision or getting a trainer to help and start doing that. So that would also come into moderate level of training. So I would advise a combination of both, because studies show that a combination is the most effective.
Yeah.
And I'll also tell the other benefits. It's not just going to be weight loss. So even if the girl is not losing weight, she will start noticing a loss in her visceral fat. So she should take measurements of her waist circumference, and she would notice a change in that. And also, after say 3 months, if I call her back to get her lipid profile done again, to get her OGTT done again, there would be a significant difference in that. So I have to tell her that the only goal is not weight loss. Like, she doesn't have to just look at the weighing machine. She has to look at a lot of other aspects.
Parameters.
Perfectly put across, Jayati. Wonderful. You did a very good job. They need not look at the numbers on the weight scale. Because it may not show a difference immediately. It will take some time to show a difference. What happens is the fat content comes down and the muscle bulk goes up. So when the muscle bulk goes up, they may not actually see a weight loss. Of course, they might see other differences like you put across. So quite often what happens is they look at the scale, they find the numbers same, and they get so demotivated. And sometimes they even go into a depression. I did so much and then my weight has not gone down, and they tend to eat more and put on more weight. So this is what happens. So when we are looking at weight loss in the PCOS, we need to tell them, don't worry about the numbers and don't worry about the weight. You just continue to do the exercises, and it can bring the kind of change that we want to. And definitely there will be a good sense of well-being. And it's like charged battery. The moment you exercise, they feel they will have much better energy to do other works.
Even the endorphin rush really helps in the depression which is associated with PCOS.
Exactly.
So if nothing else, you tell them to continue for that well-being feeling, and how it's making a difference in the blood picture when they come to visit next.
Exactly. So when it is only weight gain, because when they do only walking, I find often girls saying, adolescent girls saying that I go walking. Walking does burn calories, but it does not burn enough calories. Walking might be okay for an elderly woman, but for a young girl where she basal metabolic rate is good, she needs to actually burn calories by probably jogging or walking at least briskly. And if not anything else, she can close the door in a room and dance to her heart's content, to any one of the songs. And if she does that on a daily basis, I've had girls who have done that and who have managed to lose weight and
Lose weight
feel good
and
about it.
become a
So
good dancer.
yeah, whatever they like to do, but as long as they are physically active throughout the day, no, they should cut down on TV time. And
Even weight maintenance, I would look at in a positive way, that at least you've not gained more weight, you know.
exactly.
So that
Yeah.
that would be another positive way of looking at it and counseling her.
Yes. So much about the exercise, needs a lot of conversation about it, but we don't have time here. Dr. Teja, how would you regularize this girl's cycle? She has come to us with irregular cycle. She's 17-year-old and she has got prolonged periods. How would you go about regularizing her cycles?
I would ideally start her on a combined contraceptive pill with ethinyl estradiol, somewhere between 20 to 30 micrograms, you know, in that dose. With the second generation progestin, either levonorgestrel or norgestimate, norethindrone. This is supposed to be quite effective. I wouldn't definitely go in for ethinyl estradiol and cyproterone acetate, because studies have shown, evidence has shown that there's not much effective. And moreover, there is slightly increased risk of the DVT, thrombosis. So,
Yeah.
this would be the best option. And all of us know that estrogen suppresses the LH and brings down the ovarian androgen production, and also increases the hepatic production of sex hormone binding globulin, thereby brings down the free testosterone level. So it does, apart from regularizing her cycles, it also brings down the features of hyperandrogen excess, that is acne and hirsutism. And this can be seen as early as 3 to 6 months. And they say almost 70 to 80% of them at the end of say 6 to 9 months, they'll find good relief in their symptoms and signs also.
Yeah, Jyothika has something to say. Yeah, yes, Jyothika.
We're talking about COCs. Because we're talking about regularizing the period, so I will add it when I'm talking about androgen excess. But about 20 micrograms, there are reports that say that 20 micrograms of estradiol may not be sufficient for this girl, because it doesn't help her to have increased bone density. That's one thing. And secondly, it may not help her again to control the cycles.
Yeah, more than anything, cycle control will not be possible with very low dose estrogens. Very low dose estrogens are good for
30 microgram would be okay.
30 is the
with,
aim at a 30 microgram tablet.
Yeah. Okay. Now, so when it comes to cycle control, COCs are the best. That is what we said. And the combination depends upon what you want to use, whether she has got very severe androgen, whether she is bothered by her hirsutism acne, or whether she's not concerned so much about the hirsutism acne and it's a menstrual irregularity that she's worried about most. Then you would use different combination for these kind of purposes. Now, how long can she take this COCs, Teja? Supposing she's a 15-year-old.
17-year-old. No, she's 17-year. Okay, so I think it will be fine to give her for a year. I don't think there's any problem. But at the same time, if I was dealing with a girl of say 14 or 15 years, then I would just give her for a short time, to control the bleeding and the cycle. And then maybe for about 3 months, or at least 4 cycles in a year. So something like that I would like to plan in a younger girl. Whereas in this particular patient, 17 years, I would put her on COCs for at least a year. I think that should be quite okay.
That should be okay.
Can I just add a small practical point?
Yeah.
See, when we prescribe COCs to teenage girls, there's a small concern. Oh, you're giving her contraceptive pills. What if somebody sees and thinks otherwise? So you need to counsel them on this matter. And there are products available without that contraceptive kind of labeling. So you've got to choose what you're prescribing. I mean, the appropriate ethinyl estradiol and progesterone. The other option would be, particularly in those with very prolonged cycles, you can give them only progesterones. Only progesterones.
We'll come to that, Arul.
Okay.
Jyothika, you wanted to say something?
Yeah. What I would like to say here is, because we're talking of COCs and adolescents, recommendations say, guidelines say that we should not start as far as possible COCs within 2 years of menarche, or at least, after the age of 14 years. Till that time, we can give it for a short course, but not for cycle control.
Yeah, I got it. And similarly, like Dr. Arul said, that was a wonderful input. Like when we are prescribing COCs, we have to tell the mother that this is not for the purpose of contraception. Of course, we all know that it can work for the purpose of contraception in adolescent girls. But then when we are talking to the family, we have to tell them that this is not for the purpose of contraception, but more for cycle control that we are prescribing. And it's going to be for a short period only. Now, yeah.
In India, we need to be more careful about these things because PCOS Act is there.
Yes, yes. Dr. Arul,
Yes.
you're talking about progesterones to manage her menstrual irregularities. Can you deliberate? Can't we give a progesterone and manage the menstrual cycle irregularity?
It's quite possible. And when we give only progesterones, first of all, there is an estrogen excess in these anovulatory cycles. And progesterone is what is actually missing or lacking. So if we give only progesterone also, you can have her to take 5 or 10-day courses of progesterone and get withdrawal bleeds. This can be done at intervals of maybe 2 months or 3 months, so that she gets about 4 to 6 periods in a year. Yeah. This can be done particularly for those girls who do not have periods on their own, not the ones who have very frequent cycles.
Yeah. So those who have very lengthy cycles, it can be used for getting withdrawal bleeds, and it can be used for controlling her menorrhagia also.
Yes, and secondly,
the estrogenic side effects. However,
the particular progesterone used also you can choose. If it's only for withdrawal bleeds, medroxyprogesterone acetate is gentle and fair enough and efficient. Whereas if it's for bleeding control and a tighter control on cycles, something like norethistyrone would work better.
Yeah.
And one more point to add to the COC treatment is that if the girl has come to you particularly from a dermatologist clinic with a lot of acne, and if she's on retino A preparation, it would be wise to put her on Pakka COCs, because we don't want her to conceive at all when she's on retino A. And this can be explained.
Again, go to PCOS now.
Appropriate way, we need to tell them that, see, our concern is there. Because if we give her something and she also conceives, that you gave hormone tablets, you gave this, that, and finally this is what has happened, and she's on retino A. Yeah. So we can probably get one mutual benefit out of it.
Yes, Jyothika, you were about to say something?
Yeah, I was just thinking, progesterones are ideal for the younger ones where we don't want to start COCs.
Exactly.
Those, less than 14 years or within 2 years of menarche, we can use progesterones for cycle control rather than start them on COCs.
Yes, exactly. But see, if we are looking at a little older girls and they do have this androgen excess problem, then progesterones will not be useful, because it does not have the kind of an effect that estrogen brings in, like SHBG, etc. So if it is only menstrual cycle irregularity that we are looking at, progesterones would simply be wonderful. Yeah. Now, how can the acne be managed, Dr. Thejavathy?
Like we were talking, in each and every aspect of treatment of PCOS, lifestyle modification is the first and the foremost thing we should address. and not temporary like the other medication. It's a permanent, lifelong. So that point should be stressed to the the girl and the
Really?
family. Secondly, there are certain topical, in case if she doesn't have much of a problem, there are some topical applications she can use, like some antibiotics and the other applications. But if it is moderate to severe, yes, we have to start her on COCs again, because COCs, like I have already said, with the second generation progestin, do have are very, very beneficial in bringing down the acne and even hirsutism. Maybe in patients who don't respond to the topical, then you will need to give them systemic medication like your isotretinoin, and then anti-androgens, the CPA, and the spironolactone for hirsutism. So depending on, of course, there are others like peels. You get the salicylic acid peels, which may help in, say, the mild to moderate kind of acne.
That comes from the dermatologist, or the light therapy, chemical peel. And yeah, the best thing is, from our side, we can put them on combined oral contraceptive pills. That will help to bring down the acne, and the rest of it, I think, has to be dealt with by the dermatologist. Lifestyle changes has to be the foundation stone in the management. Now, if this girl had bothersome hirsutism, like instead of acne, then she does not have acne, but she has got a lot of hirsutism, and it's really troubling her sense of well-being. How would you go about treating her?
This itself is enough of a chapter of one talk. Management of hirsutism. Anyway, now most of these girls, when they come to us, they first would have gone to the beauty parlor and done a lot of stuff by themselves. It's not as if as soon as they see a little bit of hair sprouting over, they come to us. They don't. They go to the beauty parlor, they do some cosmetic procedures like bleaching, shaving, plucking, waxing. All these would have been done before they come to us. Now, when in spite of getting all these done, and if the frequency of these therapies are increasing, then they come to us. So when they come to us, the first thing which we can again give them is COCs. Now here, I would like to mention that COCs, the progesterone part of COCs, especially for hirsutism, especially for acne, we should only prescribe those progestational agents which are more progestational in their effect, like desogestrel. Now, desogestrel is more of a progestational agent, so it does not cause androgenic effects. Now, when you take LNG, levonorgestrel, it is androgenic in nature. So, in a patient coming with hirsutism, do not prescribe a COC which contains LNG, but prescribe one that contains desogestrel. Usually, they come in the strength of 75 micrograms. Now, the other aspect of LNG is that it also decreases the sex hormone binding globulin. So there are more free testosterone, bioactive testosterone roaming around. So it is better we be careful, just don't prescribe any COC. I repeat it again and again because this is what is seen most of the time. So a little bit of attention to the progestational agent will go a long way in helping her. Now, by COCs, within nothing happens for the first 6 months. So you have to counsel the patient that it will take time to have patience and to take pictures of herself, of her face at the beginning of treatment, say after 3 months, after 6 months, just to know how much of a change there has been. Now, if after 6 months of COC, and of course, lifestyle modification goes throughout in all cases, there is no improvement. Her hirsutism is almost the same or just marginally better. Then in that case, we have to start them on anti-androgens. Now, when we talk of anti-androgens, we can either put her on cyproterone acetate along with estradiol, or if that is not the case, because that will be again another COC, we can put her on anti-androgens per se. We have spironolactone, the most commonly used anti-androgen. That is an androgen receptor blocker. Now, this can be given in the dose of 50 to 200 milligrams twice a day. The only problem with spironolactone is it causes irregular periods. Now, she already has irregular periods. And if spironolactone is given as a single therapy, her periods are going to go haywire. So you have to co-prescribe COCs along with spironolactone for two reasons. One, that her periods will become regular with COCs. The second thing is spironolactone, in case she conceives. We don't want to think about it in India, but the possibility is always there. So in case she conceives and she wants to retain her pregnancy, in that case, if she has a male fetus, spironolactone can cause feminization of the male fetus. So it's very essential that we see that they have absolute contraception going on. Now, the other anti-androgens are, you have finasteride, flutamide. All these are given in a dose of 5 milligrams a day. The only problem with these drugs are that they can cause hepatotoxicity. So we need to do the LFT before we start, and we have to keep monitoring her throughout her therapy. But they are very good. Now, the other thing which we have to look at cosmetically is laser. Yes, photoepilation is done in a very large scale nowadays. Many sittings are required. But again, one word of caution here. If the patient has not, the girl rather, has not been on COCs, I think first we should give her a course of COCs for at least 6 months to get the maximum benefit of COCs, and only then you give her photoepilation. That is one thing which we should remember. Now, apart from laser, the other local treatments are, topically we can give her eflornithine cream, about 13.9%. Now, eflornithine has, it inhibits ornithine decarboxylase. This is very decarboxylase. This is very important for the growth of hair. So once it inhibits this enzyme, what happens is the growth of hair comes down. This need not be given solo. It can be given combined with anti-androgens, or it can be combined even with COCs or even with laser, and it works beautifully. The only problem is sometimes the girls complain of burning folliculitis. A new drug also has come into the market, and that is fluridil, that also can be checked out. Now, this is all about treating her hirsutism. More than anything else, we should remember that hirsutism, according to your estimation, may not be much, but adolescents are very sensitive about their looks, and even mild hirsutism, which you wouldn't otherwise bother about, can cause her a lot of depression. So we need to look at hirsutism and acne from her perspective than from our perspective, and treat her accordingly.
One thing is the way we know that the patient is responding to the treatment is by the frequency with which she needs to do the epilation, either the all the cosmetic procedures. It may not stop immediately. It may not stop at all, for that matter. She'll perhaps have to continue it for quite some time. But then the frequency with which she is doing, she's getting it done, will come down, and therefore you know that she's responding to treatment. And you put it across very nicely, Jyothika, that all these patients should first be on combined oral contraceptive pills for some period of time before they actually start off on major treatments like laser and electrolysis, etc. Before they started, they need to be on COCs for some time, just to make sure that no new hair comes up. All that it does is to remove the yes Jayati, you will definitely add to whatever I'm saying, I'm sure. Please go ahead.
My sister suffers from a lot of hirsutism, so I've done a lot of extra research into this. And after talking to a lot of dermatologists, I've realized why there's a tussle between gynecologists and dermatologists. The reason being that the hair which has already come out because of the androgen exposure, the hair follicle has an irreversible change, and it will always keep making a vellus sexual hair, that particular hair follicle. So that will not be changed by any COC, even the anti-androgenic kind of COC.
No.
So that has to be destroyed by photoelectrolysis. And the new hair follicles will be the ones which will get affected by COCs to make sure they don't have vellus hair when the hair grows out of those follicles. So yes, 3 to 6 months, I would say 3 months, not 6 months, is how much you should try. But if you tell the girl to, take photos or see how it's improving just on the pill, there might not be a dramatic change, because the old hair follicles will keep producing that very stubby, hard hair. So
Terminal.
that needs laser treatment, is my understanding after a
No,
lot
no,
of
your
years.
understanding is quite the same as our understanding also. What we are trying to impress upon here is that, yes, there will be a lot of intolerance to the hairs coming up for any girl who's complaining of hirsutism. After all, it is her life, her face, and
Yes.
what she has to put up with when she goes out. So, having said that, the purpose of COCs is to perhaps increase the effectiveness of all the laser and electrolysis,
Definitely
so that
increases
so that while the laser and electrolysis is pulling out the hairs that have already come up, the new ones don't come up that frequently, right? They do come up, but then it doesn't happen as quickly as otherwise it would. So that is the purpose of
hair follicles would not be exposed to so much androgen, because the blood levels of androgen would be decreased. So they will make soft hair.
yeah.
And the old hair follicles, which already have a tendency to form the vellus hair, will get destroyed completely, or they will have an irreversible change happening that would not allow them to get exposed to androgen so much. So
Wonderful.
I think a combination is what I would advise all my patients from an early stage, especially an adolescent who's bothered by hirsutism. It gets very bad.
Yes. So with that, we move on to the fact that polycystic ovary syndrome. Yes, Jyothika, we're still stuck with the hirsutism.
No, there is one thing which we need to remember.
Yeah.
That's a syndrome called the SAHA syndrome, SAHA, which is commonly seen in adolescent PCOS with hirsutism. SAHA stands for seborrhea. We did not mention much about seborrhea. Of course, increased seborrhea would have resulted in acne, but seborrhea, hirsutism, alopecia, SAHA syndrome. So this is something which we need to remember when we're seeing our adolescent girls.
Yes. We realize that what we deal with when we look at an adolescent PCOS girl is the problems that she faces at this point in time, but also need to deal with problems that can come in later on in life. And for that, definitely she needs to take cognizance of the fact that she needs to act upon it now. So the problems could be type 2 diabetes or cardiovascular problem, cancer. Her quality of life definitely can be affected, and a whole host of other problems can arise due to polycystic ovary syndrome. And so abdominal obesity, insulin resistance, hypertension, dyslipidemia can in turn give rise to type 2 diabetes, coronary artery disease, cardiovascular disease, then liver problems, cancers, etc. So the Androgen Excess PCOS Society currently recommends all women with PCOS, all adolescents with PCOS should be screened with an OGTT and a complete lipid profile. We were not doing this before. We were treating them for the PCOS. We would give them some gyan about PCOS, but all adolescents have to get an OGTT done, 2-hour OGTT done, and complete lipid profile done. And this is very important, because this is where we can lay the foundations for her metabolic problems that will come up later on. Now, Jayati, if you notice this in our girl, the girl that we are dealing with, what would your response be? What would you think?
This is acanthosis nigricans, and my first thought would go towards metabolic syndrome. So, and PCOS is also an independent factor for metabolic syndrome. So, I would do a full evaluation for her, starting with her weight, height, BMI, check her BP, check her waist circumference, ask her about the kind of diet she's taking at home, her level of physical activity, because lifestyle change is what she requires, and then order all the tests that are required for me to clinch the diagnosis, and also to motivate her to make those lifestyle changes. So OGTT would be the most important test, and lipid profile.
Yeah,
So
thank
these
you.
two would be the most important blood tests.
Yes, acanthosis can be present. Acanthosis nigricans can be seen in other situations as well. Basically, it indicates insulin resistance. Can be seen in a whole host of other situations.
Yes.
And yes, Dr. Jyothika, you wanted to say something?
You said it, Sushila. I
Okay.
just
Insulin resistance.
But it's very frequently seen in women with polycystic ovary, young girls with polycystic ovary syndrome, and therefore, it only gives us an indication that definitely it is even more important in this woman, in this girl, to get a glycemic profile done. How do you assess the glycemic profile, Jayati, now that we are on this?
Ideal would be an OGTT and check the value at the 2-hour post glucose test. And otherwise, if she's not willing for it, at least an HbA1c and an RBS, or HbA1c plus FBS would also do.
Yeah, if nothing, sometimes they may not be wanting to come for an OGTT.
Yeah.
And in such situation, at least get a fasting plasma glucose or a HbA1c done. And when and where would you use metformin, Dr.
Metformin,
in
yes,
PCOS?
it's quite a drug in the basket. I would consider metformin in those who have high BMI, insulin resistance clinically, that is acanthosis nigricans, or those who have a strong family history of diabetes mellitus, like both parents being diabetic, or if her OGTT is showing an abnormal value. So in these situations, I would straight away recommend it. This is more for the metabolic aspect of it, not for the cycle control. I would tell her that, because for that she will need lifestyle change and COC or progesterone, etc.
Okay.
But when I start metformin, I would certainly put it across to her that this is not a weight reducing drug. And this is also not because she's a diabetic that I am starting her on this drug. So with these two things, definitely I would explain before starting a person on metformin, and tell her that this is not a short-term treatment. This will go on and on and on for months or years, and even well into her pregnancy when she falls pregnant, etc., and that it is safe enough to continue.
Yeah.
So this would be my way of starting metformin. So it's mostly in obese PCOS, although it can be given for the lean PCOS with other risk factors.
Yes, yes, Jyothika, I know you will want to say metformin and lean PCOS. Come again, we'll see.
Yeah, there are studies which show that metformin works better in lean PCOS than in obese PCOS, surprisingly, because we always associate metformin with a reduction
Obesity,
in
yes.
but
Yeah.
in practice, it works better in lean PCOS than in obese PCOS.
Yeah, when you are looking at the metabolic profile of the girl, where there are lipid abnormalities and where there are glycemic intolerance, metformin definitely can make a whole lot of difference. But compared to lifestyle modification would probably score a little better than metformin. Having said that, it is something that one needs to be on, and when we as physicians are prescribing metformin, especially in an adolescent, we need to be very careful about it. There are other insulin sensitizing agents also. These are insulin sensitizers. Metformin, it decreases the peripheral resistance, and therefore it increases the insulin sensitivity. There are others that are available in the market now. What is your experience about this, and do you use them in adolescents? Any one of you can take this question.
I use only metformin.
No, we have myoinositol, which is also has been studied in polycystic ovarian syndrome. I'm not very sure about studies in adolescents, but myoinositol also produces very good results in a dose of about 4 grams a day, and especially when and this is more in obese PCOS more than in lean PCOS. Unlike metformin, myoinositol works better in obese PCOS.
Yeah,
But I think you have a different preparation also for women with normal, weight. You have a combination which works for obese and the normal weight.
not that I know of. I
One more thing, Sheila.
yeah.
Apart from metformin and myoinositol, there are also many studies on N-acetylcysteine. And they
Yes.
found that N-acetylcysteine
Mhm.
works better than metformin. There are no comparisons with myoinositol, but it works better than metformin and without the side effects of metformin. So that is, I don't know,
That's what another.
recent as 2018 in the Obstetric and Gynec Journal, and even one from Sharda Jain from Jogi. So I think we need to look at that also.
Yes,
Another one more important thing I wanted to tell, when we start them on metformin, I think it's very important to counsel, them that they may have certain side effects, like, especially gastrointestinal. And I have had patients who come with, fainting attacks and severe hypoglycemia, metformin. I've had patients. So I think we should counsel them when we start them with metformin, that this GI effects, nausea,
side
vomiting.
effects can be there, but
Yeah.
metformin will not cause
No
hypoglycemia.
hypoglycemia, and
Will
that
not
too
cause
only
hypoglycemia.
in
It can
PCOS
cause
there is a doubt.
Giddiness they had, maybe because I was thinking.
No, this is one thing that I tell all my patients, that we are not using it here as an anti-diabetic agent, and
Yes.
that it is used to increase the sensitivity to insulin. And though it is called as an anti-diabetic agent, it will not bring down their sugar levels, because otherwise they will tend to faint every other day. So I
Absolutely.
tell them that it does not bring down sugar levels to below normal. Now, having said that,
One more thing is there about metformin, Sushila, which we need to make everybody aware. It interferes with B12 metabolism. So when you are giving metformin, and we know that every Tom, Dick, and Harry is on metformin, they have to be also given by folic acid and vitamin B12 as a backup therapy so that they don't have strokes.
yeah. Now, with reference to myoinositol, when I find a young adolescent who comes with irregular cycles, a little bit of hirsutism, and a BP is around 130/90, many of these would have had a BP of 130/90, and I'm trying to talk to her and convince her to lose a little weight, to start exercising, etc., etc. Initially, to take off this kind of a change in lifestyle, I have found myoinositol to be useful. One, because it is easy for me to tell her that it's a nutrient and it is not a drug, and it is easy for, but only hindrance to the use of myoinositol, as far as I am concerned, is the cost factor. And I have found that, if you ask them to take, they do take, but after a period of about 2 to 3 months, they do not take it continuously. But if I'm able to convince them that this can bring down a little bit of it can bring about a few changes in the lipid profile and all that stuff, and they start using it, and subsequently, even if they don't use it, I have convinced them enough to continue their lifestyle modification. That is where I found myoinositol to be useful. Yes.
Yes, Sushila, I think the side effects are an important thing here. They don't have any side effects with myoinositol.
They have absolutely no side effects at all with myoinositol.
Main effect, cost.
Only hindrance I said is the cost. And I found it to be quite useful in some of the girls. So, initially I start them, but that is depending upon their affordability again. Because there's no point in taking it for 2 days, 3 days, and then stopping the whole treatment.
A
You
lot of them
cannot say
also
that it is not
report,
effective.
decreased in that bloating feeling that a lot of PCOS women have, the lower abdominal bloating and fat. After myoinositol, I've seen a lot of them come back after 2-3 weeks saying that they just felt better, and maybe an inch loss, 1 or 2 inch loss also, 1 or 2 inches. So, and again, no side effects. And I also advise it that it's a nutrient, it's a micronutrient for the ovaries. So there has been a very good, feedback regarding it, but they don't continue for more than 2 months, most of them.
Yeah. Yes, Jyothika?
Well, apart from all these, there are some other studies nowadays about vitamin D and probiotics.
We were coming to that.
Yes.
Coming to it? Okay, I'll wait.
Yeah, you can take it on, because the next thing that I was planning to discuss was vitamin D. Vitamin D, there are several papers where vitamin D has been used in the management of PCOS, and some of them have come up with very good results. So, and it is something that is doable. It's once weekly and should be okay for the pocket also. The only disadvantage with vitamin D is we don't have numbers to say yes, it is useful or no, it is not useful. So to that extent, with reference to PCOS, vitamin D, there are quite a few papers saying
Yes.
no.
And probiotics too.
And probiotics.
Probiotics too, yeah.
Probiotics will come up in a big way, I think, future.
Yeah, to that extent, there is one app called Max, which works like a probiotic because it has got alpha galactosidase, and that is found to be useful in some women who are not responding to the usual myoinositol. So yes, probiotics definitely can make a difference.
Sushila, you were saying about the preparation. The plain Apcod is for the normal weight. Apcod obese is for the overweight.
Yeah.
And
Yeah.
the Apcod max is the one which you're telling. So Apcod plain is for normal weight people.
Yeah.
So Sushila, this comes to the gut microbiota in PCOS, which
Yes.
is coming in a big way now.
Yes, yes. So there's a lot to be said for the gut microbiota. Ultimately, we either tend to give credit everything to the gut microbiota, or there will be a time when we take away all the credit also. But having said that, a lot of it can be due to the gut microbiota, and that is where some of these probiotics are found to be extremely useful in. But on their own, this is for long-term effects. But on their own, they cannot make changes in the menstrual irregularity or bring down this androgen excess symptoms. On their own, they cannot do that, but they will be, in the long run, they are likely to be useful in changing the metabolic profile of the patient.
Vitamin D also has an anti-inflammatory effect. So the
Yes.
gut microbiota theory talks about how it's a pro-inflammatory condition. So vitamin D and probiotics both together would help in going towards an anti-inflammatory profile, and that would help regularize. And both of them, like vitamin D also acts as a secondary messenger or as a nuclear receptor, which would help in bringing about changes at a cellular level that we are again not as well aware of right now.
More studies are required.
I have a small problem here in prescribing several medicines to the adolescent.
No, it's so sad.
So it is difficult to make them take. Rather, if they can be convinced to take a proper diet, they will get their vitamin D, they will get their nutrition, their gut microbes will also be in order.
They'll have
So
to
a correction from their side itself can probably work better for the long term.
I
mean, this
agree
is
with
just
you,
a thought.
Arul. None of us have any doubt about it. We are agreeing about that. But there are situations where, in addition, this particular drug or that particular drug can come in a little handy. That is what we are talking about. None of these, either the N-acetylcysteine or the vitamin D or the myoinositols, have been actually evidence-based. They have not been proven to be useful in cases of PCOS. But having said that, there are yes.
They are proven to be useful, but they have not yet come out as recommendations.
They have not come out as
Still studies need to be, more studies need to be done.
We need to have larger numbers. Thanks for the correction, Jyothika. Yes. So till such time in an occasional patient where we can prescribe, yes, it will be worthwhile prescribing these with the full conviction and the awareness that yes, this is what we are doing and this is the kind of effect we are expecting from the medication that we are prescribing.
There's also a
I think we'll go ahead.
aspect to this. A lot of patients now, after they've taken a year of COCs or they've gone to a dermat and a gynecologist, they're like, I just don't want hormones, just make me get okay in a natural way. So these would also be the patients I would put on probiotics and vitamin D and myoinositol, because these are all like supplements. They're not technically medicines. So they really respond well to that, and I put them on a progesterone withdrawal along with this diet advice as well as the supplement advice. And I tell them it will be slow, but if you want it to go about a natural way, then be prepared for it to be a slow change. So they do respond well to that because they're very tired of taking COCs, and they're very tired of all the side effects associated with it.
And one more thing is, by the time they come to you after 1 year, COCs would have produced the maximum effect also.
Yeah, and you tend to take the credit for the benefits COCs produced. Yes, they do. See, ultimately, all said and done, there is basically the fundamental treatment for PCOS is lifestyle modification, and all that we are trying to make a change here is in dealing with the current problem she has come to us with, whether it is menstrual irregularity or whether it is an androgen excess problem. That is a current problem that we're dealing with. But the basic tenet of the treatment is lifestyle modification, changing her diet and exercise, and maybe her outlook to PCOS.
Yes.
Outlook to PCOS. Now that we come to the last question. We have said that the girl's mother says, doctor, she gets her period once, and this is to Jyothika. Once in 6 months, and it is not heavy. Isn't it a better, since she can concentrate on her studies? She gets a period once in 9 months. It's okay, no, why should I bother? And quite often they don't bring the girl to you also, thinking that anyway it is okay.
But the thing is that we need to counsel the mother that she is saving on pads, all right, but her daughter's future is at stake. That the stigma of PCOS has to be explained to her, that she can have reproductive problems, she can have problems with getting diabetes later in life, hypertension, and cancer. So all these things have to be explained to the mother, not to frighten her, but just to see that her daughter follows treatment and is totally involved with lifestyle modification.
Yeah, see, basically here she needs to have a withdrawal bleed at least 4 periods a year in order to prevent her from going in for endometrial cancer at a later on stage. Do these women, Teja, have an increased risk of endometrial cancer, women with PCOS?
Yes, a lot of studies have been done. There is almost, I think, 10 to 15 times increase in the incidence because of prolonged exposure of the estrogen on the endometrium. There's no doubt about the increased incidence of endometrial cancer in PCOS, no doubt at all. But the other cancers, the breast and the ovarian cancer, breast cancers, of course, there is, the studies have been done and they have found not much of a difference in PCOS and non-PCOS. Ovarian cancers, yes, few studies have shown increase, whereas other studies have not. Maybe the oral pills, oral contraceptive pill, which we use in PCOS, sort of protects them from, getting ovarian cancer, thereby it nullifies the, risk. So yes, yeah, the endometrial cancer, no doubt about it.
Yeah.
Breast cancer and ovarian cancer, not much of a difference.
What do you say, Dr. Jyothika? Quickly.
Just to make a point here, that I can safely say all the cases of endometrial cancer in young women, not just talking of adolescents, young women, have been found only in PCOS.
Yeah.
Thank
you. Thank you. I thought you were going to say something to the reverse.
Something different.
There is no increased risk of breast cancer or ovarian cancer in PCOS women. So this is the last aspect of it, but it's an extremely important aspect.
Yes.
What about the psychological impact of PCOS on adolescents? Jayati, I think we have gone beyond the time. Can you quickly sum it up?
I think, as I mentioned, it's a very sensitive time to be going through pubertal changes for any girl, and a lot of body image issues, a lot of wanting to look a certain way because they see their idols, or they see, in popular media how one should look. And they're putting on weight, they're having a lot of acne and hirsutism issues. So they do get body image issues. As well as PCOS is independently associated with mild depression and anxiety. So all these factors do come in. So when I'm counseling, I would be looking at a few signs or screening for some signs of whether this girl is a bit depressed or anxious, or ask her in a very gentle way if she's not happy with how she looks, or when I'm talking about her exercise goals, what does she expect out of it. And if I find it serious enough, I would definitely refer her to a suitably qualified health professional, a psychologist or a psychiatrist, if medication is to be started for the same.
Thank
And
you.
impact of lifestyle changes would also, help in reducing the depression and body image issues.
Yes, so that's very well put across. So the while we are talking about PCOS, there are primary prevention of PCOS is by bringing about a change in the environment, the society that we live in. We need to talk, we need to walk about PCOS. Need to talk about it in schools and colleges and ladies club as health professionals, because we get to know about about this particular clinical syndrome. And unless we bring in an awareness about this to the rest of the population, they go by what is written in the media, what is written on the net, and sometimes it can mislead them. So therefore it is our responsibility to bring an awareness about it in journals, talk shows, etc., and emphasize lifestyle changes. I would emphasize lifestyle changes to all adolescents. We don't have to wait for them to become PCOS. This is something that I would advise for all adolescents, the healthy diet.
All of us.
All of us put together. And I would emphasize, see, there is a particular time during their school curriculum which is allotted for physical training. A PT class is there, and most of the time many of our girls are found finishing their homework during their PT class, or sitting in a corner along with their friends and catching up with their chatting, etc. But very few of them actually go to the ground and play. Physical activity is very much limited. So that needs to be emphasized to the girls and to the parents and to the school authorities also. So participation in sports activities should be increased in schools. That much encouragement can go a long way in preventing PCOS. Thank you all for a very patient hearing, and thank you, my dear faculty, Dr. Jayati, Dr. Teja, Dr. Jyothika, and Dr. Arulmozhi, for all your wonderful inputs. I'm sure it has been beneficial. At least it was useful for me, many of the take-home messages. Thank you all.
Thank you, Sushila,
Thank you,
for this
Sushila.
wonderful
Very good.
panel discussion.
You did a very good job.
Yes.
Thank you.
Useful.
Hello, Chitra.
Yeah, thank you, ma'am. Thank you very much for this excellent interaction of yours. And there are a lot of comments, ma'am, for the overall interaction that has happened. I think there is one question which is there in the chat box. Dr. Prachi, can you take that?
I'm answering it. I'm answering
Yeah,
it.
sure, doctor, sure.
Yeah, go ahead, Jyothika.
I answered it.
You answered can be given for 1 year. Okay.
Right. So, ma'am, this they won't be able to see because you are in a different chat room. So, can you just highlight on that so that people can hear it?
This one, spironolactone, can be given for 1 year, and when it is prescribed, it should be co-prescribed with a combined oral contraceptive pill. Like, it should not be given alone, it should be given along with the COCs, for the reasons that Dr. Jyothika explained during our conversation, that spironolactone can cause irregularity in menstrual cycles, and it can also, and one can conceive while on spironolactone, which can cause feminization of a male fetus. So it has to be co-prescribed with a combined oral contraceptive pill. Am I right, Jyothika?
Perfect.
Yeah. Anything else?
No, ma'am. I think rest of them is more of the comments for excellent presentation, discussion.
How many people watched?
Ma'am, that data is right now not available, but more than 180 doctors have logged in. That was the initial registration. So as of now, in this, I'm not able to see. But many more have logged in and get the benefit.
Doesn't matter at all. We enjoyed the conversation.
Yeah, same here.
We are in different parts of the city and different towns also. One is in Delhi, one is in Trichy, and two of us are in Bangalore. So we enjoyed the conversation.
But basically, all of us are from CSI.
Yes, Hospital.
Yes, I hospital.
Thank you and wish
Very
you
good.
all a
Thank
very
you.
good evening.
Thank you, Bala.
Thank you,
ma'am.
thank you
Thank you,
everyone.
Thank you, ma'am. Thank you so much. Thank you very much. Thank you so much. Thank you.
Thank you, ma'am. Thank you.
See you all.
Hi, Chitra. Thanks a lot.
Thank you, ma'am. Nice presentation, ma'am.
Again, on January.
Chitra is, using some other name, so couldn't make out.
He comes in the name of Shield. Chitra.
Okay, then see you all. I have another online class. Thank you.
We
See you all.
require
Bye-bye.
a meeting on 3rd Jan, Chitra.
Huh?
Ma'am,
3rd January, Chitra.
3rd January, ma'am.
Yeah, Dekas Teja. ಎಲ್ಲಿದ್ದಾಳೆ ತೇಜ ಹೋಗೇ ಬಿಟ್ಲಲ್ಲ
ಅವಳು ಇದು ಇವಾಗ ಎಕ್ಸರ್ಸೈಸ್ ಸೆಷನ್ 6